In this video, we will discuss syntax trial in detail. Let's first quickly go through some data from pre-syntax trials. These trials included patients with either isolated proximal LAD lesions or complex coronary artery disease. These trials showed no difference in clinical outcomes of death and MI between two treatment arms at both short and long-term follow-up, leading to profound selection bias. Second, there was no scoring system used to classify these patients depending upon the disease severity. So, the outcomes of trials from all patients together, irrespective of disease severity, were reported. These two factors were addressed in syntax trial by including all-comer trial design and by using syntax score to classify patients. Now let's move to syntax trial. It was all-comer prospective randomized controlled trial which was designed to compare relative efficacy of both treatment strategies in patients with de novo severe coronary artery disease, either TVD or left main disease or both, who were deemed suitable for both treatment strategies. In other words, it was designed to establish non-inferiority of PCI compared to CABG. The patients with stable or unstable angina or atypical chest pain with de novo coronary artery disease and target vessel stenosis of 50% or more were included in this study. If the patients were asymptomatic, then positive evidence of myocardial ischemia was needed. Previous PCI or CABG, acute myocardial infarction, the need for concomitant cardiac surgery were the exclusion criteria. Now moving to primary and secondary endpoints. The composite of major adverse cardiac or cerebrovascular events during the 12-month period after randomization was the primary endpoint. The results of trial at 12 months were reported in 2009, while the results at long-term follow-up, that is at 3, 5 and 10 years, were reported in 2019. The rate of overall MACE, the rates of individual components at 1 month post-procedure and at 6 months, 3 and 5 years post-allocation were the secondary endpoints. Quality of life, cost and cost-effectiveness, syntax score at 1 month post-procedure and at 6 months, 3 and 5 years post-allocation were the additional pre-specified secondary endpoints. The predefined subgroups which were used for subgroup analysis were age, gender, diabetes, proximal LAD involvement, bifurcation or trifurcation lesions, and the total length of stents used in a particular patient more than 100 mm. In this trial, heart team consisting of a surgeon and an interventional cardiologist used syntax score to decide whether the anatomy was suitable for both treatment strategies, CABG only or PCI only, and accordingly the patients were divided into 3 groups. Those who were equally suitable for PCI or CABG were randomized and included in the study, while those who were unsuitable for PCI were included in a nested CABG registry, while those who were unsuitable for CABG were included in a nested PCI registry. This is the flowchart showing how patients were divided into 3 groups and then further analyzed and followed up at 1 year. Now moving to results at 12 months. The incidence of primary endpoint was significantly higher in PCI arm, mainly because of excess repeat revascularization in PCI arm. Thus, this trial failed to establish non-inferiority of PCI compared to CABG. The incidence of stroke was significantly higher in CABG arm, while the other individual components of the primary endpoint, that is death from any cause, myocardial infarction, graft occlusion in CABG arm and stent thrombosis in PCI arm, did not differ significantly between two treatment arms. The deaths from cardiac cause were more common in PCI arm, while deaths from non-cardiac cause were more common in CABG arm. Now moving to subgroup analysis. In left main subset of patients with or without vessel involvement, the 12-month rate of primary endpoint did not differ significantly between two treatment arms. This is because the higher rate of repeat revascularization observed in the PCI arm was offset by significantly higher rate of stroke in the CABG arm. In those patients with isolated left main disease or single vessel involvement, the rate of primary endpoint was significantly lower than those patients with double or triple vessel disease. Now moving to triple vessel disease without left main involvement. The incidence of primary endpoint was significantly higher in PCI arm compared to CABG, mainly because of excess repeat revascularization in the PCI arm. The incidence of other individual components of primary endpoint did not differ significantly between two treatment arms. Now moving to subgroup analysis from syntax score point of view. In left-main subset of patients, low to intermediate syntax score showed similar outcome between two treatment arms, while high syntax score clearly favors CABG. In TVD subset of patients, low syntax score was associated with similar outcome between two treatment arms, while higher syntax score, more than 32 in particular, clearly favored CABG. So in CABG group, the 12 months rates of MACE were similar among patients with all three tertiles of syntax score, while in PCI group, the rate of MACE was significantly higher among those patients with high syntax score compared to those with low or intermediate syntax score. Thus, the significant interaction between syntax score and treatment group has been observed. The similar rates of MACE were observed between two treatment groups in patients with low to intermediate syntax score, while in patients with high syntax score, the event rates were significantly higher in PCI group. Now moving to the interpretations of trial. In patients with de novo triple vessel disease or left main disease or both, CABG was found to be superior to PCI with drug-eluting stents at 12 months. This was mainly because of higher rates of repeat revascularization in PCI arm. But this increased rate of repeat revascularization observed in PCI arm did not appear to translate into a significant increase in the rate of death or MI. CABG was associated with higher risk of stroke at 12 months, maybe because of less use of DAPT in the CABG arm. No difference in the incidence of other individual components of primary endpoint was observed between two treatment arms. Thus, the risk of repeat revascularization after PCI needs to be balanced against risk of stroke and invasiveness of CABG. The largest benefit from CABG seems to be observed in patients with diabetes. In patients with high syntax score, CABG should remain standard of care because outcomes in the CABG group were not influenced by the syntax score, while in PCI group, the high syntax score was associated with higher rate of MACE and the individual components of the primary endpoint. The patients with left main disease and low to intermediate syntax score may do equally well with both treatment strategies. From cost-effective analysis and quality of life assessment point of view, CABG was found to be beneficial over PCI mainly because of decrease in the incidence of angina in CABG arm, particularly in high syntax score patients. So in the intention to treat population, the number of patients needed to treat with CABG to avoid the primary outcome in one patient would be 19. The number needed to treat to avoid specific components of the outcome would be 14 for repeat revascularization, 119 for death, and 71 for MI. The number needed to treat with PCI to avoid stroke in one patient would be 60. So these are the references you can go through for further details. In next video, we will discuss the results of syntax trial at long-term follow-up, that is at 3, 5, and 10 years.